Appreciate the opportunity to be here, and I'd like to thank the organizers of the conference for letting me come and speak. I'm not a virologist. I'm actually a general pediatrician. I don't know if this will be of interest or help to y'all, but I'll get to the a little study that we did back about a year ago here in a minute. Our objectives are listed here, though. I should say that my primary objective today is just to be able to raise the question of, do we actually know what we're doing when it comes to personal protective equipment, especially in the setting of things like Ebola virus or other emergent infectious diseases? Unless you've been in a coma for the past year, you're well aware that there was a major outbreak of Ebola virus in West Africa. That is more of a issue driven home to, I think, some of us in the audience rather than others. But as of last summer, we had about 27,000 cases, 11,000 deaths. And of perhaps special interest, we also had more than 800 healthcare workers who were infected and 500 deaths in that population as well. As we all know, Ebola is primarily contracted or transmitted via contact with bodily fluids. That can happen both before and after death. There's at least one study which shows that transmissible virus was able to be picked up out of a post-mortem sample 3 weeks after the individual patient had died. There is some question about whether respiratory or aerosolization occurs, and that I think there's some growing evidence that it can actually potentially be passed along via aerosolization, WHO recommendations notwithstanding. Currently, so the personal protective guidelines for healthcare workers transmitted by or put out by the CDC includes these things. Basically, the take-home point is that you shouldn't have any exposed skin. You should have all mucous membranes that are covered. And I would point out the use of an N95 mask or a PAPR in order to protect the healthcare worker. Now, bear in mind, CDC recommendations are really set up for American hospitals. There's a different resource set potentially in places like here in Atlanta than what we would potentially have in Liberia. The World Health Organization also has a set of PPE guidelines which are similar, with the exception of the replacement of a surgical mask for the mask, the N95 mask recommended by the CDC, as well as the fact that the head covering is optional in the WHO recommendations. I didn't put in here the Médecins Sans Frontières recommendations, which actually theirs are slightly different and perhaps a little more rigorous even than what the CDC recommendations are. But I found, and this is actually, I guess, the background for why we did our little study. Back in October of last year, the American media was coming to grips with the fact that there was a large and potentially lethal outbreak of an infectious disease somewhere in the world. And as the media tends to do, there was lots of television coverage, there was lots of reports, there was lots of people calling the public health department. And so someone at the hospital as well as at the university that I'd worked had handed me a big magazine and said, you need to order a bunch of PPE equipment. So if you get on the CDC website about what PPE you should be using, they actually use the phrase, select your PPE combination, and they use this series of 4 or 5 pictures that you can click on. Each of those has a different training program. I went on to a website. This is just a materials online magazine that you can go through and pick out, and they had more than 1,900 different options for coveralls, 34 options for gowns that potentially would work for PPE, 1,000 glove options, 200 foot coverings, 37 eye protectors. You put it all together, you have hundreds of millions of potential combinations, and nowhere did they actually have a bundle that you could actually order what you needed to be able to be taken care of in this case of a potential exposure to Ebola virus or some other similar virus. Instead, you were supposed to grab each of the different combinations. Now, you add to that the fact that everybody seems to agree that training is really key to making any of these effective. So you got to wonder about the donning or doffing procedures as we put stuff on or off. And I think that leaves us with the question then of which of these is good, which PPE combination is better, is there a best, where's the data? and how do we compare? What about testing? There's virtually no data comparing different bundles of components for Ebola, and there's very little data comparing training mechanisms. I'd like to take just a moment to compare this to other industries, if you will. If you think about the automobile industry, if you're going to make a car, you do things in a piecemeal setting. You get a tire and you test that individual component of the car, that is the tire. It goes through its own sets of tests and standardization. Then you put it together with other parts of the car, and this is, I'm not a mechanic, but this is the suspension of I believe it was a new Ford pickup truck that my wife assures me we don't need. But the suspension then works together in a bundle, and it actually gets tested individually before it's all put together into a system whereby a professional will jump into the car and go driving around and off-road and be testing the whole system. And then finally, there's the real-world application of the system, and that is the car being sold on a car lot and people driving around town. All right, well, when we think about PPE, and this came as a surprise or a shock to me, there's definitely component testing. If you look at, you buy a set of gloves, they have been certified by somebody that they are waterproof or acid-proof or whatever the chemical of interest is. Those components have been certified. But nowhere do we actually have any certified bundles. There's nothing equivalent to what happens in the automobile industry. Nowhere do we have certified systems. Instead, we take a series of components and we put them together and we say, okay, we want you to go out and use those in the real world. And so then we have that same real world application without these corollaries of testing that we would expect from other industries. And I, for one, would probably not buy a car that hadn't been taken through these system testing steps. So what data is out there is there's not a whole lot. This was actually a study that came out just last month. It was by Casalino and a group. I believe there's part of the group out of Spain and part of it maybe out of Brazil as well. It was a very well done study. They had 120 learners or students, medical students, nursing students, that they divided into 4 groups. They basically had 2 different bundles of protective equipment and 2 different training techniques. Everybody got a 1-hour didactic session, and then they had 3 hands-on training sessions. And then their outcome was basically these errors identified during the task. So I would call this a process outcome. If you're I'm not a virologist. I do work sometimes in a lab. If I have a new grad student who's in my lab and I'm trying to teach them how to do RT-PCR, one of the things that I want to do is I want to make sure they do the process correctly, that we have accomplished points A, B, and C before we add the master mix and start putting it into our machine. I also, though, want to know, does the PCR run actually work? Is my positive control positive? Is my negative control negative? And what does my sample actually show? Well, in this study, just because of the difficulty with having an event outcome in a study like this, they actually looked at these process outcomes. In other words, did they do parts A, B, and C before adding the master mix with the PCR? So they had 2 different ways that they did the training. One of them was conventional training. The other one was what they called reinforced training. Basically, the difference was just the amount of involvement of the instructor during each of these training sessions. And what they showed was, as perhaps we would all anticipate, is that there was a decrease in the number of errors after they repeated each of these training sessions. So here's 3 training sessions, 4 different groups. And you notice that the curve on all these is the slant is down. They improved the processes and decreased the number of process errors. What I would point out, though, is that these are actually what they called critical errors. So this is where you have bare skin touching a contaminated or potentially contaminated surface. And we're looking at here in this one group, we still have a 40% critical error rate after 3 training sessions. None of these actually got down. We have here down in one group, we got down to 5%, which I think still most of us would say that a 5% chance of contracting an illness like Ebola would still be enough to make us concerned. And so there's still, I think, room for improvement there. The other point that I would point out is that even though we saw that repetition of training decreases errors, more complex PPE may not equal better protection. If you'll notice here, the group that actually did best was their basic PPE group. Now, with a process outcome, that kind of makes sense because we would be looking at something that if we can simplify the process, if the PPE is more simple, we would have fewer process errors because we would have fewer steps required in the PPE. But the point again is that we do know that repetition and training decreases errors in the process, and we know that more complex PPE may not necessarily equal greater protection. So back in October, when I was faced with the idea that I needed to order a bunch of PPE that I really didn't know what exactly to get, and it turns out most stuff was on back order anyways. So I actually, we kind of came up with an idea to be able to do our own testing there at our institution. And this was just a really small study. It was a fun little project that we did. But basically, we took 8 PPE naive learners. These were, 2 of them were actually medical residents who had no experience with high complexity PPE like we would use for Ebola virus. The others were nurses. We had 2 different PPE bundles that I'll explain in just a minute. We did a uniform training technique. We had an instructor who assisted with it. There was a 1-hour didactic session. And then what we did that was maybe a little bit different is that we actually, once the individual was donned in their PPE, they had their outfit on, we ran them through a simulation exercise where we actually took a mannequin and basically covered the mannequin with fluorescent dye that shows up under black light. And the idea was we have a guy who kind of at our simulation center who specializes in making vomit look like vomit. And so he made artificial vomit and artificial poo and added this fluorescent dye to it and smeared it around on the mannequin. And then we sent in our healthcare workers, once they got their equipment on, sent them in actually to take care of the patient. They had to check a blood pressure, they had to check a heart rate, a temperature, and they had to change the patient's gown. And then, so our outcome of interest was actually an event outcome, and that is who actually got contaminated during the exercise. The 2 different bundles, one of them was one that we already had on hand that the hospital owned a few copies of. This used a something called a striker hood, for those familiar with that. Used PAPR, met the CDC guidelines, actually exceeded, both of these exceeded the CDC guidelines at the time. It was all commercial components, cost about almost $7,000. The striker hood is actually reusable, so the remainder of it, the disposable part of it, was about $350. The other bundle was one that used an N95 mask, and other than the N95 mask, I actually went to a local department store, wandered around through the sporting goods section, and just bought stuff from Walmart in order to put together an ensemble that also met the CDC guidelines, but only cost $25. So here was the commercial product, again, striker hood, very nice setup, about $6,700. Here was the homemade, again, I'm cutting this with a pair of scissors, but again, technically meets the CDC requirements once we put on the final component, which was actually the face shield there at the end. So we had, what were the results of this? Again, it's a very small study. You wouldn't draw many conclusions from it, but we actually had one patient, or one subject in each group that actually got contaminated with the fluorescent. This happened to be the one who was wearing the $6,700 suit. The individual who was wearing the $25 suit had her contamination was in a little different spot. It was actually kind of on her backside when she turned around a little bit, so I didn't put up a picture of that. But the point is that both of them actually ended up with 1 out of the 4 participants contaminated. Are there any take-home points? I don't know. Maybe. One of them is that I think that you could potentially use fluorescence as a marker for training for PPE systems, and especially since there's so many different combinations of PPE bundles that are out there. As an institution, we actually implemented a program where all of our folks who are part of our high-risk response team actually go through this training exercise, and they have to not only be able to show that they have a small number of process errors, they also have to be able to show that they don't get contaminated, and then maybe commercial PPE components are no better than others. Finishing up here with just 2 slides. So what do we know about PPE? Again, the title of this is Dressing in the Dark, and I think that when we're thinking about emerging infectious disease, personal protective equipment, there's a lot of things that we don't know. We do know with Ebola in particular, transmissions primarily via contact. Again, there's a question of whether there's a respiratory or aerosolization potential, and then the repetition of training decreases process errors. But there's a lot of things we don't know. We don't know what an ideal PPE bundle is. That would likely depend on the setting, the resource setting in which you're at. We don't know what the ideal PPE training is. That is, again, with the exception of the one study by the group out of Spain, that has been unaddressed. We don't know how many times you should train. We saw that 3 times decreases your rate to a 40% critical exposure rate, but we think we should be able to do better than that. We don't know how frequent we should be training. We don't know how do individual components of PPE coordinate. We don't know the impact of bodily habitus. If you have someone who's 7'3" and weighs 480 pounds, it's unlikely that they're going to have the same coverage with PPE as someone who's much smaller. And then a lot of things that you just see on the news, things about bleach sprays or taping, again, the data is just not there. I was actually having a discussion with some folks from WHO back, I guess it was probably been in November of last year, and that was one of their questions, well, what about bleach sprays? And again, there's just zero data on it out there that I'm aware of anyways that's been published in the literature. So as far as is there any utility to this discussion or talk today, I guess that my suggestion would be that we should really be doing some kind of grassroots PPE testing. And that is, whatever bundle you have is what you should be testing in, and you should try to find a way to be able to make sure that it works in your environment. So a few suggestions then to do that, what we've done at our institution. Once we establish what our PPE components are, we don't change them unless there's a compelling reason like they're no longer being produced. We try to choose components that are compatible with available resources. We actually went away from the striker hoods just because we couldn't afford enough of them. We try to train multiple times using the same components. We try to quantify process errors during the training exercises as a proxy for how proficient the individuals are in utilizing the PPE. And then we try to utilize simulation. Again, we do our fluorescent markers, have the participants run through a medical exercise in order to try to figure out who is going to be at risk of an event outcome. And then we retrain periodically. And with that, I'll stop.